We also do, of course, see labor trafficking, LGBTQ community, people from all backgrounds and walks of life, I guess is what I'm getting at. When we look at this and we think about where does a model like this lead us to, I just want to step back real quick and talk to you about the ramifications this has had for me in my medical practice and for that of my residency. So I'm a program director for a residency program. I have 24, I'll have 30 residents in family medicine that work through our program. Now, in the past, we never identified a person that was being trafficked within our outpatient or inpatient clinical settings. Our reality today is, of all these patients that we're currently seeing, over 90% of them report that they were seen by a healthcare provider or physician while they're being trafficked, and none were identified. And you know, that story is something I've seen in my own experience many times. I'm just thinking back to a case of a patient that always sticks out in my mind that I saw a while back, and she was 18 years old, and she was coming in with her 5-year-old, and she was being trafficked the night before and was picked up by law enforcement. They got her out, got her into the safe house, and she was in her office the next morning. And as I was talking with her and going through her medical history and her chart, I looked back and we had medical records in our hospital on her. And I went back and looked through those. And 5 years prior, when I looked at when she had a delivery of the child that was with her, and I looked through those records, she was 13 years old at the time. She was marijuana positive when she came into the labor and delivery floor, you know, virtually no prenatal care. And guess who delivered that baby? You know, it was me and my team and my residents. And we did the delivery, we got social work, we got everybody involved, and we thought we took all the right steps, identified all the right people to help with her case, and we discharged her home. And a month later, we admitted her baby in for an acute life-threatening event. And it was, again, me and my team that took care of her. And what's really interesting to me is that not only did we discharge her back to her trafficker during both of those events, but even looking through her medical record, we very clearly documented all the warning signs and symptoms that would now be clear to us that she was being trafficked. So part of this learning curve in medicine means that myself and others, my residents, my faculty physicians, we now routinely identify our patients within the clinical settings we work that are being trafficked, and we can help get them assistance. And then we've been able to take that and create this, again, longitudinal wheel where we are able to provide a full scope range of care for these individuals that can be everything from pediatric preventative medicine to prenatal care, women's health. We deliver their babies when they're hospitalized. We take care of them in the hospital. When they go through surgery, we take care of them post-op. So this has really become a full scope, like one-stop shop where these individuals can receive their care. And we've been able to collaborate, you know, with so many different organizations. I just put this picture in on the side, but it reminds me that, you know, I've worked very closely with our local FBI since we've been able to create books of the branding tattoos, you know, on our patients, and been able to share those with our local law enforcement. So when we talk about doing this, I think it's always really important that we have a lot of people that are coming into and that are interested in human trafficking, and a lot of lectures that are given on human trafficking really take this like 30,000, 60,000 foot view, looking at the problem, but it's very, very difficult to ascertain how you can actually apply that logistically into the work that you're doing. And so one of the things that I encourage people to do is, no matter what background you're coming from, make sure that whatever training that you're giving is validated. When we created training, working for, you know, providing information and training and education to our residents that was going to be really patient-centered and something that they could use, I wanted to validate it. And so I used all the appropriate or available tools, like this was the healthcare provider human trafficking training assessment tool that was produced by Heal Trafficking at the time. I used this, but then I modified it significantly to make it very logistically applicable to the residents. And then I went back and went through, and all the residency, well, there are 6 different residency programs in the state of California. I went through and provided the training on human trafficking for each of these within the Dignity Health system, and then did a study on it looking at the before and after skills, knowledge, and attitude. And we call that the Truth Study, training residents on understanding trafficked humans. And I mean, it's intuitive, right? Their attitude, their skills, and their knowledge got better. And of course, that's what you're going to anticipate. Now, as we started developing workflows, how we're going to do this, how we're going to do it in our clinical practice, we created entire different ways of getting patients roomed, getting them contacted. We have an embedded advocate now working within our facility that just works with this patient population. But as we made all these changes and went through this process, I wanted to make sure that it was survivor informed every step of the way. So not only getting feedback again from law enforcement, from case agencies, social work, but from the patients themselves and from their caseworkers who very often were survivors of human trafficking, making sure that we were implementing all of the practices so that this was survivor informed. And again, using the best tools available. So this is the survivor informed practice self-guided assessment tool. And this can be looked up online and comes down through the governmental agencies. We have a lot of really good patient outcome data that's come out of this, and I'll talk a little bit more about this in a minute. This is going to be probably, to me, when we look at this slide and we're talking about, well, we're decreasing PTSD symptoms, we're decreasing depression scores, anxiety and stuff. That's all nice, and we would anticipate that. But when we talk about trauma-informed care, and when we talk about the application of these principles of survivor-informed care, victim-centered care, and meeting these patients really where they're at in the trans-theoretical model of change, how do we know that any of that, these theoretical topics actually work? And there's almost no data on that. If you look up trauma-informed care, it's pretty ubiquitous right now throughout medical literature. It's in a lot of, I'm sure it's in the social work and even law enforcement, all over the place, right? We're seeing trauma-informed care being incredibly important. And intuitively, it makes sense. But again, do we have data to back that up? Because a lot of things that we may think or don't think make sense may or may not actually work. And so we spent a lot of time actually coming out with a study on this specifically, and this was recently released. This was our trauma-informed care treatment outcome study. We called it, nicknamed it the TIC-TOC study because I'm kind of a nerd and I think fun names are fun. So basically, this should be about 5 studies in one, and I'm just doing a snapshot here, but really trying to assess how do we know that the care that we're providing within our clinical setting is making an impact on these patients in their lives. And the way that we actually assess that is through one of our community agencies, Communities Against Sexual Harm, who runs an entire program, an anti-trafficking program, where they're taking, newly trafficked patients or patients off of the street or picked up by law enforcement, and they're putting them through an entire process where they get them safe housing, they work with them for employment, for educational opportunities, for parenting classes. They go through a whole bunch of different steps. And basically the bottom line is at the end of this process, that person is really set up to be able to get out and stay out of trafficking. And that process usually takes about 18 months to 3 years. Now, their success rate was typically about 15%. And if they bring a patient to our clinic, what we did is we gathered enough patients, enough patient data working with cash, that if a patient is brought to our clinic versus any other clinic in town, they have about a 437% increased chance of getting out and staying out of trafficking. Now, that's huge. That's huge. And that's data that I think really, it's an extrapolation, right? Getting out and staying out of trafficking by completing this program is an extrapolation. It's also an extrapolation to say that applying these trauma-informed principles is what led to these outcomes. But it's about as concrete data as I've actually seen in this domain. And so I was very, very excited about it. And you can see if you go through this paper that there's lots of other places where it hits, substance use disorders, mental health, and other things. Paradoxical effect on burnout for our providers was not something I anticipated stepping into this and doing this work, but we've been able to do this both locally and even abroad in other countries. So this has become a large part of what we do all day, every day. And again, just because we're talking about research, I think that we can say, okay, we've got this idea, we feel like it's working. Our patients are telling us it's working. The caseworkers are telling us it's working. We're getting good patient outcomes. Our experience is it's a very low utilization model of care. All of that sounds really good, but quite honestly, I don't think that's going to make any difference in whether or not we can actually get this adopted on a real large scale, sustainable way throughout the country, unless we can prove there's an economic benefit. And so kind of our holy grail study that's underway right now is we're actually going back through all of our patients, and we're basically looking at snapshots of what was their healthcare like leading up to being in our clinic. And what you see time and time again is a situation like this, where you see a patient, if I go back through their medical record, their emergency department visits, their ED visits, ED visits, ED visits, ED visits, they're uninsured this entire time. So the healthcare system, the hospitals are absorbing this cost of taking care of this patient that's a very, very high utilizer, being cared for in the most cost inefficient way possible within our system. And then they hit our doors, and they're here at our family medical center, and we start taking care of them. And what you see time and time again is there's no more ED visits. And now we've got them enrolled in a Medi-Cal plan. And so it's a payer that is going to not be an economic drain on the healthcare system. And so again, I mean, that's not the reason to do any of this work, in my opinion, but I also recognize that this is the work this is the study that I need to make the hospital systems and the payers buy into this this idea. And I know I'm talking fast, but all of this information, basically, we wrote up a book. How do you recreate this type of model? It's all available on our website here. And again, I've made it's very, very logistically straightforward to be able to replicate these clinics. And we've helped lots of places do them. Currently within the state of California, I did hear a lot of people came in from San Bernardino. We have one of our medical safe haven clinics in Northridge. So we've been opening up these medical clinics throughout the state, and we've put them specifically within primary care residency programs. And why do we do that? My soapbox always in talking about this, and we work on it a lot at the national level for healthcare. And I always hear the same problems, like, how is healthcare going to address human trafficking? How are they going to do it in a way that, is sustainable from a cost standpoint? How are you going to do it widespread across the country? Because most of the clinics that do this use, huge grant funding, and they do it in very high utilization settings. And then how are you going to, most importantly, train the doctors to do this? Because there's very little medical education or training on this. And so from my standpoint, what I truly believe is that this training belongs in residency educations. The residents, they've gone through medical school, they're in residency. Those 3 years they're spending in residency, the experiences they have, the patients they treat, that's going to dictate their understanding of healthcare and how they practice for the next 30 years. So by doing this, family medicine alone, we have about 550 to 600 residency programs in the country. They all already have clinics that are dedicated to vulnerable patient populations. Why not implement this training, this education, this experiential learning, taking care of this patient population within those clinics? It would be low cost. It would already be widespread care with that many clinics across the country. And most importantly, you get this ripple effect where you're training all of these doctors that are going to go out into their communities, and they're going to know how to do this for the rest of their careers. Every year I'm graduating 24 residents that know how to do this. They're opening up their own medical safe haven practices within their clinical settings. They're replicating the protocols within the hospitals they work. So to me, this really makes sense, and it can be done. This is just a picture of a physician that back in 2017 came to a lecture I was giving, and I've worked with him. I flew out to Northwell Health, the largest healthcare system in the state of New York, spoke with their senior leadership team, and they now have this medical safe haven model and protocols up and running throughout their system. So this can be done, and I really hope that we can get it adopted. So a lot of this stuff, again, needs to be very logistically straightforward. And I'm just gonna skim through this very quickly, but I just want people to understand that this training, this education, this application, replication of this type of model of care is not a 30,000 foot view. It's not a 60,000 foot view. This is a view where you can actually take this information, start seeing patients, and apply the model that we're doing. And it really goes down to this, like, we've created tip sheets for providers when they're seeing these patients that literally walk through What are the important points that you want to do if you're getting ready to see one of these patients? How are you going to walk through the actual encounter? What are the important concepts and ideas that you want to think about? How are you going to do the physical exam? When you're doing a procedure on these patients, how are you going to do those procedures? Labs, imaging, referrals, how is that part going to work? What do you do after that initial patient encounter? How do you create follow-up? How do you take care of yourself during that process? And I mean, it's even down to the logistics stuff, like what labs do we order? And everybody's going to be thinking about like STI labs, STDs, sexually transmitted diseases, but there's a lot of other exposure labs like quantiferin gold for tuberculosis. There's going to be immunization titers because so many of our patients come from backgrounds of abuse and neglect. There's going to be a whole list of malnutrition and almost like refugee lab work that we recommend, and because we find a lot of positives in here. But this wheel's been built. This is what we're doing. These are the findings that we have. And it even gets down to like what codes we're going to be putting in the medical record. So again, somebody can take our information and they can start using it. I would anticipate in about a 1 to 3 month time frame, most individuals could start seeing these patients on their own and be working with community agencies and building those collaborations. And again, the medications that we even most commonly use. Now, I do want to start getting a little more in depth here now.
The following part of this presentation does include some explicit case studies of sex trafficking victims that could be emotionally triggering for people who have experienced sexual violence. If at any point during this video you feel the need to pause or entirely stop watching the video, we encourage you to do so. We acknowledge this is a difficult field to work in and hope you take care of yourself in the process.
And this is really going to be the main part of today's topic. We're talking about, or the reason that I was contacted by HD Radar was about a paper that we published on basically where complex post-traumatic stress disorder coincides with trauma-coerced attachment or trauma bonding, and how do we best treat those patients? And I'm going to walk through this a little bit. And I want to do it by bringing up a patient example, because I think it's going to go through a lot of the concepts that we're going to be discussing over the next 20 minutes or half hour. So the case of MG. MG is a 19-year-old who grew up in South Sacramento, 3 older sisters, a mom who's single in the household, Section 8 housing, moved around almost yearly. Mother started drinking heavily during patient's middle school. Around then, patient left school and home and moved in with a friend at the age of 14. Patient began slowly getting into the game, which obviously means trafficking or the life, at age 12 to 13, when a friend introduced her to an older man that paid for sexual services. Eventually, one encounter led to another. Patient was approached by men she believes because how she was addressed initially. Later, she learned about the strip off Stockton Boulevard and began walking there, the Blade there in Sacramento. Eventually, patient became involved with the trafficker at age 16. He was 10 years her senior. First, he was nice to her, began controlling more aspects of her life, cut her off from her family, began physically, emotionally, sexually abusing her. He would never use protection with her and tried successfully to impregnate her the year prior to this appointment, and forced her to do cocaine, marijuana, ecstasy, and drink alcohol until she was sick repeatedly. He was trying to get her to have a miscarriage. When this did not work, he forced her to go to have an abortion at 4 months of gestation. She did leave this trafficker for another trafficker and ended up with chlamydia a couple of years prior to the appointment. After this, she returned to her original trafficker. He beat her for leaving until she blacked out. Since that time, she describes difficulty concentrating. Despite this, she felt like they could have a relationship again. And I put this in quotes: sometimes he was good to me. Johns were forced to use condoms. Johns tricks dates, just the buyers of sex. She was removed from trafficking situation and placed in a safe house 3 days prior to being seen. She feels anxious but safe there. She has had problems sleeping at the safe house, currently experiencing nightmares, also describes hypervigilance, repeated startling, dissociative symptoms, sees her trafficker as someone that looks like him around town and feels scared. She has started some trauma therapy already with a psychologist to communities against sexual harm. She's interested in getting healthy, but is very against medications, as her trafficker used to force her to use various drugs at times, and the doctors kept putting her on meds, telling her she was bipolar and had ADHD when she was young. Also wants to be a lawyer in a community agency, has connection with a law firm where she may have an opportunity to work with a paralegal, which is exciting to her. She is also currently having vaginal discharge and pelvic pain. So a fair amount of stuff going on there, but I think what we're going to see in a couple of minutes, I'm going to bring this case back up, and I'm going to show you that these themes that we see in this patient are themes that we see over and over again with not all, but the vast majority of patients we see that come from trafficking backgrounds, and specifically those that come from trauma that is complex and chronic, and often originates at a very early age. So what we are seeing, what we are learning is that a trauma-informed and victim-centered approach is ultimately the mechanism for delivering quality healthcare from a position of empathy. And again, this is very widespread in the medical literature. And it's a nice topic that I think everybody appreciates and understands. And again, is intuitive. And we know that this works in so many different demographics in the patients we see. So these are all different types of patients in our clinic. A 22-year-old male trafficking live in domestic work, a 66-year-old female foreign national labor trafficking in a nail salon, an 8-year-old female sex trafficking sold by her mother, a 17-year-old trans male sold for sex by his foster family, 38-year-old nurse sex trafficking survivor needing routine preventative care. So trauma-informed care and the application of these principles is going to be very, very important. But I really think we're still missing a core conceptual framework for understanding these patients and caring for them truly when they have these backgrounds of specific types of exploitation. And I use this quote because it's one I hear variations of all the time, where my patients say, you know, that part where we got out of trafficking, like that part was the easy part, like keeping me out, that part was hard. And why is that? And I think, again, that goes back to that misconception that so many people enter this field with, that like, we just need to get patients away from their trafficker and they'll be all right. You know, get them away, get them in a safe house, get them employed, and all of a sudden, you know, they're out of trafficking. But it's so not that easy. And we really are misunderstanding the ramifications of complex PTSD when it coincides with trauma bonding or trauma-coerced attachment, and those types of chains that's going to bind that person to that trafficker. And I'm going to go through, you know, a little bit about that here. Now, if we're thinking about PTSD, we're thinking about trauma, it's really a continuum of complexity, right? So exposures to trauma occur along this continuum. It can be a less complex single-time incident like a car accident. And a car accident can lead to PTSD, and it can be real disabling, completely impact somebody's life. And I'm not discounting that at all. But more complex PTSD that comes from repeated, frequent interpersonal violence is a very different beast. And this is going to be the history of most of our patients, where they're going to have chronic trauma, the experience of early, multiple, persistent, overwhelming events. And that's going to be mixed with complex trauma, where you have the impact of chronic trauma on brain development and symptomatology over a lifetime. You know, when you look at non-complex PTSD, this is stuff that's in this article that is in the Journal of Human Trafficking. You can Google it online. The full article is free to review. This is one we published called Trauma-Coerced Attachment and Complex PTSD, Informed Care for Survivors of Human Trafficking. And in it, you know, this article, we're discussing that when you look at non-complex PTSD, arising from a single event or a limited time frame, even on neuroimaging, you can do neuroimaging studies that show these changes in the brain: decreased hippocampal volume, hyperactivation of the amygdala, hypoactivation of the prefrontal cortex, the hippocampus. Complex PTSD, you see actually consistent but very different changes occurring. And this is, you know, complex, again, resulting from complex trauma, where you have the exposure to varied and multiple traumatic events, usually over a prolonged period of time, often interpersonal, where escape is difficult, and developmental, often beginning in childhood. And the neuroimaging is going to see hippocampal complete dysfunction, a decrease in actual gray matter, prefrontal cortex activation disturbances, and more severe functional changes than with non-complex PTSD. And why is this important? I mean, I'm using this really as an example to highlight, like, not only are we talking about potential differences between the treatment of non-complex PTSD and complex PTSD, we can see that there's actual neuro, you know, functional changes on imaging. So why would we be treating these two the same? And then we even take that a step further, because when we talk about treatment of PTSD and we're thinking about acute versus chronic versus complex, none of that yet puts it in context of trauma-coerced attachment. You know, and when we think about trauma-coerced attachment or trauma bonding, what are we talking about? Trauma bonding was a term. It was initially developed by Patrick Carnes, who did to describe the misuse of fear, excitement, sexual feelings, and sexual physiology to entangle another person. I prefer the use of the term trauma-coerced attachment. It's a little newer, and I like the definition a little more. It involves a powerful emotional dependency on the abusive partner and a shift in world and self-view, which can result in feelings of gratitude or loyalty towards the abuser, and denial or minimization of the coercion and abuse. And when you think about what that means, I think about the typical story of a patient coming to our clinic, and I use this story a lot, and I think it really exemplifies this concept. We have this patient that's going to be coming in from this background of abuse, trauma, and neglect. It's interesting to me that only about 21% of children that run away in the country each year get reported to the police. These are backgrounds of exploitation, abuse, neglect already, right? And so some point in this child's life, maybe they're 12, 13 years old, they get fed up and they're going to boldly hit the streets. And, on the streets, the trafficker knows exactly where to pick them up. So we're using MG here. So trafficker knows exactly where to pick up MG and takes her home for a while. And at first it's going to be really nice to her. He's going to wine and dine her, take her to dinner, do different things, buy her new dresses, whatever. And then at some point that trafficker gets mad and he just beats the bejesus out of MG. And he takes her down off of Auburn Boulevard here in Sacramento, along the railroad tracks, very scary, bad part of town. And it'll be the middle of winter, freezing rain here, and he'll dump her out on the railroad tracks. He'll strip her naked first. He'll do something awful like pee on her, and then he'll get in his car and he'll drive off. And now you've got MG sitting there, and she's a 12, 13-year-old girl. She just ran away from home recently. She's just gotten beat up. She's naked. She's freezing. She's on the railroad tracks. And it's not like law enforcement knows she's there. Us in medicine, we don't swoop in and save her. But who do you think comes back and gets her hours later? It's going to be that trafficker, right? And he's going to bring her home and he's going to draw her a warm bath. He's going to take her to dinner and he's going to buy her a new dress. And then he's going to go through this pattern of beating her and abusing her again. And you think about this doesn't happen once or twice. This happens over and over and over again during the developmental years of MG's life. And you think about the psyche behind that. This type of abuse, reward, punishment, alternation, this is creating the chains. This is creating those psychological chains that I think are stronger than any physical chain we could ever run into. So that's really what we're up against when we talk about this. We're not only talking about those changes in the neuroimaging that we see with complex PTSD. I truly believe, and this is not something that I've been able to find in any of the literature yet, we need to do these same studies on somebody that's really experiencing trauma bonding. And I believe that we're going to find that there's reward pathways that are lighting up, very similar to those that we see in substance use disorders. And I say that in part because of my clinical experience of providing a few thousand patient visits. We see a lot of overlap here. So what actually happened to MG early on? She ran away from the safe house, and I always think about that. The analogy I use is, you have somebody whose entire life is pedal to the metal, foot on the gas. It's all fight or flight response. It's all stress hormones being released. And then you take them out and you put them into a safe house where it's quiet and calm. How unfamiliar is that? They're hearing crickets that night. That's going to cause somebody to bolt, right? That's going to cause all of the complex PTSD symptomatology to rear its head. So what did she do? She returned to her trafficker. He beat and raped her and she stayed with him. He sold her for sex and she stayed with him. But why? Well, what we're seeing from a healthcare standpoint is most of the literature we have to be able to treat these patients comes from veteran affair literature. There is some newer stuff coming through. But the strength of recommendation for treatment of PTSD, A being the best, C being the worst, you can see that some of the psychological treatments like cognitive behavioral therapy is good, cognitive therapy, some of these are pretty good. We have to put into account that traumatic brain injury may reduce their efficacy by up to 50%. And most of my patients have had that to some extent, so the efficacy may be dropping, but there are some decent psychological treatment plans. Also, there's a lack of resources to be able to utilize those in many of our patients. And on the pharmacological treatment side, we can see that the medications that we use fluoxetine, paroxetine, venlafaxine, strength recommendation B. These are the only ones with any strength of recommendation from our leading agencies, the Agency for Healthcare Research and Quality. Now, using any of these medications to me is like using a BB gun on Godzilla. Like they're something, but they sure aren't going to do the job. And the low strength of recommendation medications, we may find that there's a lot more benefit with. But again, that's because we're treating a different beast than the PTSD that the studies have been done on, that arises from very, very different timeframes in a person's life and more limited timeframes. So I'm kind of stepping back here. When we think about this again, the reward pathways that somebody is going to be building from that abuse, from that punishment, I believe that you're going to end up with those, that it's going to overlap again a little bit with substance use disorders. And I'm going to come back to this slide in a few minutes. But really, I think what we have to do is we have to approach this individual using the same type of trans-theoretical model of change, where somebody's either pre-contemplative, thinking about change, contemplative, or they're in an active phase of change. Because when we use this with patients that want to stop smoking, stop drinking, other things, we have more success if we meet that patient where they're at in that state of change. When somebody's being trafficked and they don't identify themselves as a victim and they don't see the problem with being abused and neglected part of the time and then having these kind of rewards at other parts of the time, they may be in that pre-contemplative phase of change, and hitting them with the tools that we might use for somebody in the active phase is going to be not only counterproductive, it could potentially be harmful. So we really want to meet the patient where they're at. I mean, I think that's just kind of the bottom line, and do it in a way that's victim-centered and survivor-informed. This is a wheel that we put into this paper that, again, is something we see over and over again. Somebody's coming from this background of developmental trauma and vulnerability that leads them into a trafficking situation where they're experiencing chronic complex trauma. They get what we hypothesize are stress-induced reward pathways being stimulated or dampened. This is while they're in the trafficking situation. Then they get pulled out, via law enforcement or some other measure, case agency meeting with this, and they get put into a safe house. In that safe house, taken away from the stressful environment, this is what we see over and over again. This is when the patient's PTSD symptomatology now arises, where they have insomnia, they have nightmares, they have anxiety, they have the incredible emotional ability, the ups and downs, anger outbursts, the fear, all of this occurring. And what does it lead to? It leads to this trauma-coerced almost attachment withdrawal. Like you almost see this withdrawal from the intensity of that environment that they were used to living in while they're being trafficked. And that person bolts, they run away from the safe house back to either substance use, or they fight and flight back to traumatic situations, high intensity situations, back into trafficking. And so again, even with our agency that we work with that does so much wonderful work, the success rate of getting somebody out of trafficking and keeping them out of trafficking is incredibly low. And I'm sure all of you have seen that. But we're missing the boat if we don't look at this. We don't take into context the fact that this person is almost withdrawing from that type of intense situation potentially. And how can we help mitigate that? Well, I personally believe that a lot of the benefits that we see in our patient population come from the use of some medications short term that mitigate some of these parts of the wheel. So for my patients that are experiencing hyperarousal, a lot of fight or flight response, a lot of stress hormones, and they're having nightmares at night, a little prazosin will decrease that adrenergic load. That'll decrease the stress responses that they're having. It will also take away their nightmares. Some of the mood stabilizing agents, a lot of these fall under the category of atypical antipsychotics, but basically they do a couple of things. They decrease the mood ability, and they also cause a little bit of sedation. So now you've decreased the emotional ability, you've decreased the PTSD symptomatology. And then a third agent that I very often throw in would be one of the SSRIs like Lexapro or escitalopram. And what that actually helps is there's a thought that a lot of the PTSD symptoms are cycling in our kind of primitive hindbrain, and they never get up to the frontal cortex where we can process them and basically move past them. And so the SSRIs are thought to help in that effect. Now, throwing in all of these medications, if I did nothing else for my patients, I think I would see an enormous success rate in my patients getting out and staying out of trafficking. If I did nothing else than put my patients on 5 milligrams of prazosin, 100 milligrams of Seroquel at night, and 10 to 20 milligrams of escitalopram. They're really that effective. But again, this doesn't exist in the medical literature in this patient population. Well, it does with this paper, but outside of this, I've never seen it. So I think this is an incredibly important slide when we talk about treating these patients. I will also say that when we do this, this is not long-term necessarily. When we showed those imaging studies of the brain and how it's firing and the disruptions that we see in somebody that's experienced PTSD or complex PTSD, and you also see this in substance use disorders, is over time, those brain pathways go back to what we would consider more normal functioning patterns. And so what I think about with this is these are medications we're going to use for 3 months, 6 months, maybe a year, and then we're going to be able to be pulling them off because they won't be needed anymore. That person's in a safe, stable environment. Those brain pathways are literally being re-equilibrated, and so now they're doing well. And again, that's been my experience treating these patients. These don't tend to be long-term medications for many of them. Many of them do this for a while, and then as their life goes in this new different direction, we're able to pull them back off. Substance use disorders, something I would just touch on here is that what we often see is that, traffickers are in control, and some of them will put their patients on substances to control them. Some will restrict them. Really, the key here to me is exploitation, and I think that that's really important. I also will say that, again, my anecdotal experience, this isn't in this slide set, and I'm totally talking off the cuff. I have no evidence to back this up. But I personally feel that when I have patients that come from trafficking backgrounds where the trafficker was forcing them to use substances, and now they're coming in with like heroin use disorder or alcohol use disorder or various different types of substance use disorders. Very often it's polysubstance use disorder. I feel like I have an actual higher success rate in this patient population than I do in my general patient population. And I think about the rationale or reason behind that. In the general population, about 20, maybe 20% of us have the genetic predisposition for substance use disorders. We're exposed enough over a long enough period of time, and our bodies are going to, create a physiologic addiction. I think when the trafficker is forcing that, we have a lower percentage of people that are going to be within that domain, just statistically. And so I guess what I'm getting at is I feel very good about being able to get many of my trafficked patients off the substances and having them get into periods of long-term recovery or abstinence, even better than my general patient population. The piece I would touch on here with mental health disorders is I can't tell you how many of my patients come in and they have these histories of 1 million mental health disorders, where they were diagnosed with bipolar and ADHD and a conduct disorder and all these things, during their upbringing or early life. And what I find is that many of those patients were diagnosed 10 years ago, when they were 13 years old, when they were being trafficked, when they're on methamphetamines. And you take those people out of those situations and they never have any of the signs or symptoms of this underlying disorder that they've been diagnosed with. And I really think that many people were mislabeled early on with these diagnoses because of the experiences of exploitation they were undergoing. So what I find is that as often as not, we're being able to pull off, these kind of historical mental health disorders that I think were probably given inaccurately, again, by providers such as myself that weren't aware of the context or educated on human trafficking when they were given. So if we just take some of these themes and we put them back towards MG, we can see here are things we see over and over again. She's growing up in a situation of vulnerability. It's a poverty, it's Section 8 housing. She has developmental trauma early on in her house. She has secondary trauma when she met her trafficker. She has the forced drug use by her trafficker. She has this potential traumatic brain injury. He's beating her till she blacked out and she can't concentrate. That may alter, is cognitive behavioral therapy going to be as efficacious for her? It's something I at least need to be thinking about. She says she might still have a relationship with him, and sometimes he was good to me. That's just alarm bells that We're dealing with trauma bonding or trauma-coerced attachment in the midst of all of this. She's in the safe house. She's been there a little while. She feels anxious but safe. Now we're hearing the crickets, right? She's resistant to medications because what's happened to her before, but she's experiencing these obvious PTSD symptoms now that she's in the safe living environment with her nightmares, hypervigilance, startling, dissociative symptoms. And again, she has these questionable mental health issues that have been given in the past. Whether or not those are legitimate, we've got to find out with time. So again, we take this type of individual and we say, well, the success rate of getting and staying out of trafficking is incredibly low for her. If we apply these medications, this treatment plan, we're not going to get everybody and keep them out of trafficking, but we're using these medications, we're doing this stuff, and we're going to see that her success rate is going to go up potentially 400+%. That's a big change. That's a worthwhile endeavor to go into that and try to deal with, treating her appropriately using these parameters. Now, I have actually a number of other case studies here. I don't know that we want to go through all of them. I don't think that we have time to go through all of them. Because correct me if I'm wrong, we have about 10, 15 minutes left.
That is correct.
Yeah. So maybe I'll just hit on a couple of points in each one. Just knowing I had saw the breakdown of the audience, so I think there are a few points that are important. This one is a 32-year-old female former human trafficking victim into established care and evaluate chronic pelvic pain and infertility. Her history was being exploited starting at age 13 until she was 26. She had a guerrilla pimp who would physically sexually abuse her and force a bottle in her vagina and anus, which caused pain and bleeding. This part here, she heard about our clinic providing trauma-informed care by physicians who are educated on human trafficking and wanted to come in. She is concerned about her history may have affected her ability to have children. The negative encounter she had with her prior physician was startling. And, this sounds crazy and off the wall, but this is what she told me. She said she was seeing a physician across the street. And at this point in her life, she's successful. She's put together. She, you would have no idea that she had been trafficked. But she had said she had talked to her physician and said, I've got to talk to you about some issues I'm dealing with. And it has to do with my history of being sex trafficked when I was younger. And she said her physician, this woman looked at her and smiled and said, wow, that's amazing. You were sex trafficked. That's so cool. And that seems ridiculous, right? But I don't fault that physician. I fault our medical education system, because I'm sure that physician had some kind of glamorous idea of what trafficking was. They probably thought of the movie Pretty Woman and thought of her like rags to riches story. And again, if we don't change the education that we're providing our law enforcement, our medical providers, and others, we may have incredible misconceptions about what this person has been through. And then again, how do we deal with something like infertility? This is the ramification of her being trafficked at age 13, leading to STDs, leading to infertility issues. So how do we work with our healthcare system to try and get this patient care when truly she had no control over what happened to her and her body at that point in time. So those are kind of little theoretical ideas or thoughts to think about. This one, I know we have a fair number of law enforcement in here, and this is probably something that I'm preaching to the choir, but this was a case where we had a 25-year-old female in for abdominal pain, nausea, vomiting, throwing up blood. She'd been doing well, living in a safe house, working to complete her work study program for job placement. She was in our clinic for quite a while. She reports she was returned to the game after her prior trafficker saw her walking down the street and threw her into his van. Things went bad quick, and she was subsequently sold for sex throughout the Bay Area for 6 weeks. While being trafficked, she reports being raped and beaten by her pimp, who was trying to impregnate her. She did not have unprotected sex. Otherwise, the Johns wore condoms. She did drink alcohol and smoke pot. She found a chance and was able to flee. She ended up homeless and was eating waste food the past 2 days. She eventually made it back to Sacramento and returned to City of Refuge, her previous safe house, who brought her right in. She couldn't eat much. She had abdominal pain, And when I saw her, she was all beat up, bloody and bruised and dehydrated. And I just admitted her to the hospital because she had, rebound guarding on her physical exam. I didn't know what was going on. And in her workup, she was pregnant, probably from the trafficker, most likely, because he was the only one having unprotected intercourse for her. She had all these cuts, bruises, and scars. The trafficker was texting her while she was in the hospital saying, get out of that hospital, ho, you're costing me money. And so we had all of these things. To me, it's like slam dunk, get law enforcement, get everybody involved. Let's get this trafficker put away. And she wouldn't talk to anybody. And the reason she wouldn't talk seems like, well, why wouldn't you? But after he had picked her up, he drove her around his gang, and he pointed out her mom and her little brother. And he told her, if you come back and you say anything to anybody about who did this stuff, this is who we're coming to get, your little brother, your mom. And the DA here in Sacramento will say that's not an idle threat. So there can be very, very concrete reasons why these individuals are very, very reluctant to disclose information or talk to people when it feels like, why won't you? I'm going to skip this one. And I'm going to end with this one. This was a 16-year-old female AP brought on by a mother, referred by Child Protective Services to our clinic, current victim of human trafficking. I spoke with her and her mother, not present. She has this history, kind of unhappy at school, single mom works all the time. She doesn't do too many drugs, but a few here or there. Found some individual who started putting pictures of her back on Backpage. So you can see this a while back ago when Backpage was around. And other websites offering sexual services for money. They were arranged by this friend who is currently incarcerated. She performed oral sex, foot fetish activities, but hadn't had vaginal intercourse with any of the Johns. Her mom had been distraught over this activity and was working with FBI and CPS. Patient describes generalized feelings of sadness, denied suicidal ideation, had weight loss and intentional. Anyways, she does want birth control. She was honestly, she was dressed like somebody was trying, like somebody that thought this is how I should dress if I was trying to sell myself for sex. She was completely flat in her affect, a little bit tearful, but almost depressed beyond tearfulness. I'm sure many of you dealt with that before. What do you do with an individual like this? Like FBI is involved, CPS is involved, but mom works nights, and it's not like people can sit and babysit her 24 hours a day. And so this was a very tough situation to be in, but by meeting her where she was at in this pre-contemplative phase of change, by having her get connected with some of our community agencies that have peer support groups, that have trauma therapists, by working really hard to treat her depression and anxiety with the appropriate medical management, and by following up with her like very closely, consistently over the next few weeks, months, and then years. This was my note 2 years later. 18-year-old female in for follow-up for depression. Patient has been doing significantly better on Lexapro ever since switching to half dose following last visit. She is looking for work, wants to go to cosmetology school. She is no longer involved in trafficking situations, happy, smiling, no insomnia, adequate appetite. We spent part of the day looking online at application process for applying to her local community colleges. So, such a change in the direction her life went by getting the right people involved. And basically the feedback from our patients is healthcare was crummy before. It's great, and it's something that they rely on, a great tool in their tool belt of their new life as they go through this road of recovery. And so really what we want to do, I want to implement these protocols across the country. I want these medical safe havens to exist across the country. I believe they should exist in residency training programs so that we train our doctors of tomorrow to do this care. And thank you. That'll be the end of my presentation. I put a couple of our websites up there. The data on them is getting old. We're in the process of updating them, but it does have a lot of information there. And then again, the TIC-TOC study, the truth study, the complex PTSD, trauma-coerced attachment. I think those are really good studies to reference, at least as far as what I think is working for treating this patient population. So thank you. And I will try and look back at this chat, unless do you think there's a better way to answer any questions?
Yes, I was actually wondering if I could just ask you the questions and then have you answer them.
Sure, sure.
We will be answering both questions on the chat and also in the room. I do want to check if anybody in the room first has questions that came up. We do have plenty in the chat, so don't feel pressured. Okay, yes?
I'll just try to project. So thank you so much. It was an incredible presentation. You're doing incredible work. One thing I'm always curious about is we talk about PTSD or complex PTSD, and then we have folks that we work with that may or may not have an actual diagnosis for that. I mean, do you just assume that's going on with this population, or is it more tailored to the individual? Like you have to go through those PTSD symptomology and get a certain number of them to diagnose it. How do you think about that?
Yeah, I absolutely don't assume, you know, people have different levels of, who knows what, cognitive resiliency. Some patients have incredible histories of trauma and exploitation and seem to have minimal ramifications somehow. And I don't know how you chalk that up against somebody who has, you know, pretty significant complex PTSD symptomatology from experiences that sound, you know, like they would not. So no, it's definitely person dependent. I think that's the bottom line to that answer.
Yeah, and we have a follow-up.
Was going to come up here to do it. Thanks, Dr. Chambers. Part of why I ask is I work in legal services with survivors, and a lot of them are not getting access or haven't historically had access to the kind of care that you're piloting in your clinics. And they either have diagnoses that are really old or they don't have diagnoses at all. And so when we're doing legal pleadings for them, I really struggle with, we always do a section on PTSD, but I can't make a claim that this client has PTSD, right? Because they don't have that diagnosis. And so I don't know how to talk about, you know, PTSD in this population, complex PTSD, without necessarily making claims that are diagnosis dependent. So I don't know if you can illuminate that at all, but when you're not talking about a specific person, like how do you talk about the level at which PTSD is occurring and assumptions, I guess, about the kind of distress people might be in, even if PTSD is not the acute diagnosis.
Right. I think, you know, I hate to venture any speculation getting outside of the medical field because I have no idea what the implications are for the legal system on that. There are scale systems. I don't know if they could be used by a non-medical provider for things like, you know, we use the GAD-7 for anxiety tracking or the PHQ-9 for depression. And we have one for PTSD. And basically it's a list of questions the patient can actually go through themselves and fill it out, and it will give you a score. And then based on the score, it kind of levels you up as far as how far or how severe the PTSD symptomatology is that you're experiencing. They are very general scales, though. They're definitely not, oh, here's the slide. They're definitely not the, they don't like account for trauma bonding, and they don't account for complex PTSD, but a lot of it overlaps, and it would maybe be something you could consider using.
I wouldn't consider using that as a legal professional because you need to be either a mental health professional or a medical professional that's trained to really analyze and understand. That's what I would recommend, getting them evaluated by someone to give them that proper diagnosis. But yeah, it's just a legal right. Well, yeah, totally understandable. But I wouldn't speak to that if you don't have the training for that, because that's going to put you not in your lane and real big space liability. And complex PTSD is also not a formal diagnosis yet. It's something that we're still researching, so it's kind of hard to speak to, especially if you're not in that profession, to say this is exactly what this looks like. Yeah, so we speak about it in general terms and don't make any claims about our clients, but I'm wondering about legal stuff is very specific. So yeah.
Hi, I'm Dr. Miller, and I teach senior nursing students, and I've been a part of this group, Human Trafficking with SHARP, and I realized that we're not teaching our nursing students to even recognize I can take this down, I can't breathe, to even, to recognize and be mandated reporters. And right now, I currently am having my students do a module where that they are mandated reporters. And I'm really, this time, I really like your presentation, and I like what Dignity Health is doing. But I really, but right now, what I'm experiencing now, because I work at a hospital, and about maybe 6 months ago, we dealt with a patient who obviously looked like, definitely looked like she was a trafficker, bruised from head to toe, weak, malnourished, couldn't even walk. And the nurses and the doctor, none of them recognized it. They allowed the John to come in, take her out of the hospital, sign out against medical advice. And I tried to work with the staff to, say that she should not go. She was on a 5150. They let her go. I wasn't on the night that they let the John come in and take her home. This is such a serious problem. I'm working over here with the nursing students to help them to recognize, but what do we do with the ones that are currently in the hospital, letting this go, letting this happen to these girls?
Yeah. Well, it's you're talking about a systemic issue, in my opinion, nationally. That's an issue, and a lot of people. I have a different opinion, I think, than some of the leadership on trafficking in the country. There's a lot of opinion that we should educate everybody and they should want to do it. And yeah, that's great, but I don't feel like it's realistic. I wish Joint Commission would come in, or CMS, and mandate protocols so that you had to have everybody trained. You had to have a protocol in place, and you had to be able to verify that you did that when they came into the surprise site visits. I'm chief of staff at the hospital. If they give us a new protocol, guess what? We all jump through every hoop in the world to learn it and implement it and do it. And I mean, it's like my hospital president's going to put in the funds that we need to do it. And I just feel like that. I know it's a big stick and nobody wants to use the stick, but in this case, I'm like, just use the stick a little bit, and then everybody will have to do it, and then we could move forward. And you wouldn't have things like that where nobody's educated or trained. Because really right now, honestly, my experience is I go to hospitals, I go to hospital systems, we beg, plead, until finally, if I can get myself in front of somebody with enough clout, I can give them a sales pitch, and then usually they bite it. Usually they're like, wow, this is really important, I didn't know, and then they do it. But it's like you've got to try and do that each and every time, and then 3 years later, that person transitions to a new job and the protocols fall apart and there's no resources dedicated to it. So I'm just of the opinion we need a systemic change in protocols to be mandated across the country.
We definitely.
And I think this education needs to be in medical education, and it needs to be a requirement.
I think some of us in the audience are professors and are currently teaching nursing students and psychology students as well. Do you have anybody who could speak into those classes and be a lecturer?
What's kind of nice is I have a lot of, myself and my faculty, and even I always say, even my residents, I have a lot of people that are incredibly adept at giving presentations and have a lot of lived experience taking care of these patients, which I think is incredibly useful when you present this information. I'm always really surprised when I hear people speaking, to governmental agencies, giving advice on the topic, and they've seen 5 patients in the last year, and I'm like, we see 10 a day, in our clinic. This isn't like, I think it's really helpful to have that experiential learning, and I do have lots of contact people within our program that would be very adept at doing that. And I could, if Les, maybe you could get me the names, and I'd hook you up with Jennifer Cox or Gigi. They would organize that.
Okay. I'll connect with you later, and then hopefully we can get an email that we could contact for that sort of resource.
Yeah, easy.
All right. And I know that we're not going to get through all of the questions, but what we have done in the past is I copy all of the questions that are in the chat, or anybody who's here in person. And then Dr. Chambers, is it okay if I email it to you and then get an emailed response that I can send out in the follow-up email?
Sure. Absolutely.
Okay. Thank you. I do know that the reason why we had this time as a cutoff is because I believe you have something in your schedule coming up. Is that correct?
Yeah, in 2 minutes.
All right. All right, no problem. Well, then I think we can wrap up, and thank you very, very much. This is very interesting and pivotal research that it really sounds like you have a utopia over there. So hopefully we can get closer to that sometime soon. Thank you again.
Thank you, guys.